Hearing a diagnosis of stage 4 cancer is perhaps one of the most crushing realities to accept. As with any terminal illness, there are big questions to answer that affect the entire community around the one who is sick. Choices for treatment are plentiful, and the need for no-nonsense, honest discussion about what's happening and what could happen is being demanded. On today's show, I'm joined by experts in the medical and spiritual fields of healing. We're here to dissect the problems that arise and the treatments that are used. We'll also explore the options available, the expectations that go with them, and inquire about the things we're afraid to discuss. Join us for a compassionate yet direct conversation so we can evolve the way we live and also the way we die. I'm Erin Donley.
I'm Dr. Shani Fox.
I'm Rebecca Singer.
And I'm Dr. Glen Patrizio.
And this is Reveal What's Real. This program is made possible by marketingyourtruth.com. All right, thank you so much for joining me for this conversation, all three of you. So maybe to get this started, Glenn, you had mentioned that 10 years ago, if you were diagnosed with cancer, 80% of those people, depending on what, it didn't matter what kind of cancer it was, that they would die within 2 years. And now that statistic is 50%. So we've made a lot of progress in the field of medicine. What are you seeing in particular with stage 4 cancer and other cancers? Can you give us like a lay of the land on what's happening in the medical field right now?
Yeah, it's interesting. We're almost the product of our own success in this thing. We've done a lot with research and in cancer care, and so we've come a long way in treating people. One is that the treatments are less toxic than they used to be, so we're able to treat older people than before.
So chemo and radiation isn't as strong as it used to be?
It's more specific than it used to be.
Okay.
We used to hit people with shotguns and suffer the consequences. In the old days, they would give people chemotherapy, and it was poison to the body, and the hope was that the cancer would die before the patient would die. Mm-hmm. And that's how chemotherapy worked. And then it became more and more specific, and so we've got agents now that are amazing to work with. And so that's really nice, because that makes cancer less of that death sentence than it was before. Although people still feel, they hear the big C and that's it, they're done for. But the reality is, in many cases, it's more like a chronic disease, which is good. But that said, there's also an element of pushing. There's a fear of death. And in the beginning, as a hospice doctor, we would joke about oncologists. The big joke about the oncologist was, they would be there, prying off the coffin lid. They had one more chemotherapy agent to give to people because that's the way it was. But as I worked with more oncologists and more patients, I came to realize is that patients came to them in fear. They wanted to live. They weren't ready to die. No one had sort of talked to them about the fact that death is part of life. And so, standing outside, not having the disease process, and I look in and say, God, there's a 2% chance this is going to work. Why the hell are they even offering it to them? Because that 2% is more than zero. And when you're that afraid of dying, you'll shoot for 2, because it's more than 0. Mm-hmm. So it's been a very different shift. And unfortunately, part of that shift is that we do a lot of what we call research protocols. And people get confused what that means. When people get very far advanced in cancers and they're trying new things, we start to look at research protocols. And people think, research protocols, this is a drug that may cure me. Whereas in reality, a research protocol is you're donating yourself for the benefit of somebody else in the future. Because the chances of you getting better, and even the goal of you getting better, is not really part of that protocol.
Mm-hmm. And is that clear when it's presented to the patient?
Well, you wonder what they hear.
Exactly. That must be so tough.
Yeah.
Now, with stage 4, it always just seems like that is like the worst of the worst. I mean, are there some types of cancer that in stage 4 that are totally curable?
Well, I want to dominate the
Go ahead, that's
conversation.
fine.
What staging does is just tells you where it is in the body. So stage 4 means it's spread. It's spread to all places that it can. So it's in more. It's stage 1. It's sort of contained, and as the stages get bigger, it's spread out farther and farther. So to say stage 4 is you've got the site and then spread out through different organs in your body. So that's all that means. Depending on the type of cancer, that may or may not mean that we're done.
So chemo might not be totally out of the question.
Exactly. Breast cancer responds well to that. As long as it's hormone receptive, you can go for years, decades with treatments.
So you said something that I'd like to kind of follow up on, which is that, well, nobody's been educated that death is part of life. And I'm imagining a kind of program that is accepted in hospitals and even funded by hospitals, where someone who gets a stage 4 prognosis has the option, as well as getting chemo or as well as receiving naturopathic medicine, has the option to take a course on what is their disease and what are they having to learn from it, what is it asking of them, what kind of resilience do they have in them with the disease. What is death for them? What do different cultures think about dying? What does the community have to offer them? What are they afraid of?
What wisdom would they like to share?
What wisdom would they like? What would they like their legacy to be? How could we start to educate people to look at, we prepare ourselves for everything in life but death. So how could we start to offer people through a course and reframe death as, let's look at this as also a part of life. And how can we move towards it with the whole family? And what do you want yours to look like?
That's a point very beautifully taken, and I would take it even one step further, which is that facing death, which should be done as openly and open-heartedly as possible, it's also important to learn how to live in the time that you have remaining,
Yes.
whatever time that may be.
Yes.
After all, none of us really know how long that is, cancer or no cancer. I had a particularly beautiful example of this in my own family. My father, when I was 15 years old, was hit by an automobile and nearly killed. He got through that experience and then lived another 28 years as if he could die any moment. And of course, that was the best way to live. There was no wasted moments and no wasted words. And so he did, in fact, die of pancreatic cancer at age 80, but he had had a beautiful, beautiful life, which even he did not regret at that point. So learning to live as well as learning to die.
And I totally agree with you. And one of the questions I have about particularly stage 4 pancreatic cancer, and having watched my dear friend die of it a year ago, and sat with him while he was in the community chemo room getting his treatments, and looking at the suffering that caused and the pain that caused in him and the total lack of good it did him, I was wondering, and it's his decision, but I was wondering, well, is this the way he wants to live? And and I think that's an important part of that discussion. And I think that people get pressured into chemo by their families. I think there's a lot of pressure to fight this thing.
Yes.
And I don't want the discussion to become chemo or no chemo, but I totally agree with you. But I think in facing death, it's the more you can face your death, the more you can live.
Yeah.
One way to sort of look at, and this sort of broaches the bigger picture, taking it outside even cancer and that thing. There's a lot of things that we can do. We have progressed very far in medicine, and so there is always something more that we can do and offer. Then the big question is, and this becomes one that actually falls into the responsibility of the medical profession rather than the responsibility of the patient or the family, is just because we can do it, should we do it?
Yes.
That fits into the stage 4 category in the sense that when somebody is so far debilitated, is what we're about to offer going to prolong the quality of their life, prolong their life, or prolong dying.
And why is that the decision of the medical person and not the decision of the recipient?
Because as a physician, when a patient comes to me and they and confide in me, or we're talking about this intimacy of their health, not only is there that subjective conversation that goes back and forth, but there's also knowledge that that a physician has about what's going on that the patient doesn't have and can't have.
Do they, though? I mean, because I think the reason I was so excited about this conversation is because I had known several people who had loved ones who died of stage 4. They chose cancer, they chose chemo, and they wound up dying of heart failure or pneumonia because the chemo just trashed their body so severely. And they felt really duped by the medical community. They felt that it was a prolonging of false hope, that, I've heard doctors get compensated financially for offering chemo. And this whole thing just got me real fired up. And as all these baby boomers progress, how can we have more honest discussion? So are these doctors saying to them, listen, here's the deal. I can offer you this another round of chemo, but I want to let you know the chances are slim, and it's gonna hurt your body more, and it costs a lot of money. Are they brave enough or able to have that conversation?
I need to dispel a myth.
Please do, yeah.
One does not get into medical school because they're nice, or that they have a good bedside manner.
Good point.
You get into medical school because you're very smart and you're very good at science. We are scientists first. We just happen to do our science on people. So that other element of communicating with people, if you got a doctor that will communicate with you and is nice and empathic, that wasn't part of their training. And the smarter you are, the more subspecialized you get, because that's how you go up in the system. So the people who are oncologists, and I have met some amazing people up at OHSU, they are incredibly smart. They're intimidatingly smart. I remember in a rotation, we had this patient with this odd thing, and the oncologist walked into the room, looked at the slide and said, oh, it's this, it's on page this, and walked out of the room, came back 10 minutes later, and we were all looking there, and it was right. He said, have you ever seen this? He said, no, I just read about it once. Yeah.
Okay, but
that element of intelligence. So when it comes down to these things, people come to them in fear. They're afraid that they're going to die, and they are.
There are a lot of kinds of brilliance and intelligence in the world, and doctors also take a vow not to do no harm. And I have to say that as I sat with my friend and the effects of the chemo, and as I sat with another woman who had her leg amputated as a last-ditch resort of how to live with skin cancer and died 3 weeks later, I have to wonder, at what point, no matter how brilliant they are, at what point are they doing no harm? I mean, at what point in a doctor's mind is it always to save life? I mean, when is there room for walking towards one's death knowledgeably with some skills and that energy that wants to turn inward, and the work that people need to do or sometimes want to do before they die, they can't do when they're in a hospital bed, undergoing huge operations, and when they're so drugged that maybe they do it, I don't know. But I'm saying there's intelligence and brilliance, and then there's
like the whole package.
There's the whole package.
Well, and is it our responsibility to seek out these doctors and not hold every single one of them to the standard? I mean, is there...
It's tough. I mean, if I go to a cardiologist, they're going to give me something heart-related because that's why I'm there and that's what is expected of me, or expected from the cardiologist. We offer because we can. We offer because we do want people to get better, and we want to give them some hope in that process. And we offer because we are human, and we're also afraid of dying ourselves. And the more that we're detached from the reality that we too will die, the harder it is for us as a medical professional or as a physician to talk to someone about death and dying. Because if we're talking to you about death and dying, then we have to have our own issues resolved about death and dying. And that's very hard.
Wouldn't that be helpful?
Maybe that's where you begin your program.
Yeah, and I think, because I mean, if when a patient, when there's a family and a patient in crisis, they may need you, but they're going to say, I don't want you right now. I've got to focus over here because this person is offering me a way out. And I think that the place where it needs to be is with the people who are doing the offering. I mean, to be able, one of the things I do when I train physicians is sort of talk to them about saying you don't have to. Just because we can, we don't have to. And you're not obligated. Autonomy does not mean giving everybody what they want. Autonomy means helping them to make decisions, and you are not obliged to do anything.
And I'm also guessing that in your approach, it's much less, it's more holistic.
My first interest is, what does the patient want? And I find that often they'll want hope of some sort, and I find that hope comes to them when they can have some part in what's going on, including making this decision about what they want. And then if they choose chemo, then they choose chemo. And if they choose not to have chemo, and I can support them by supporting their overall health in some other way, then that's what we do. And if their choice is to do absolutely nothing, that's their choice.
Shawnee, I see what you do as being so important, because we talk a lot about having a team to work with, and oftentimes that can't be a family member or even a friend, and then the medical doctor, that relationship's just different. So bringing someone like you on board who can explain, like, yes, you're going to have this chemo, let me talk to you about how herbs or homeopathy or how your diet could help the body absorb this treatment better, and that help you really work. I mean, as these baby boomers, again, the huge numbers keep growing, they're going to be seeking out people like you, and I mean, what can we say to get more of them to realize that they need to build a team, and perhaps even now, before something really bad happens?
Well, that's ideal if you start before there's ever any cancer or other serious disease. If people get in the preventive mode, obviously, then they will have their team assembled when they need it. It often doesn't happen. However, I do the best I can to get the word out, and my colleagues do the best they can to get the word out, that there are many facets to this story, that the MD is an important player, but not the only player. And so I think that the more cases we have where people get a team together such that they as a person are supported, in addition to the person who's treating the cancer or the tumor itself, those are the people who do very well often in the long run. What I like to tell my patients is that any chemo or any other treatment has a bell curve of statistics as to how successful it's likely to be. Those are people who are generally not aware of their other options. And the minute you know of and employ your other options, you often slide down the good side of the bell curve to your own advantage. And so that's what I like to do, is give people better chances by giving them an array of treatment and choices, rather than having them just rely on any one.
Yeah.
So can I ask a question?
Yeah.
I would really like your honest answers to this. Let's frame death as a part of life. Just like we eat, we grow up, sometimes we get married, sometimes we don't. We have all these experiences in life, and one of the experiences we have in life is death. And it's a given from the get-go. So culturally, we shove it aside. Medically, we don't go there. It's like it's defined as bad. So do you think that there's a possibility that people could view death as part of life and something that they could prepare for and something that they could approach with courage and something that they could approach with the hope of reconciling themselves to it in a peaceful way, and with the hope of a family gathered around them who would also be understanding and supportive emotionally of them, so that they wouldn't have the fear of being emotionally abandoned before they die? And do you think that that couldn't be a calm alternative along with all the treatment that people are getting? I mean, the reason I ask this question is the years I spent living in the rainforest in Costa Rica. You could look on the ground and you wouldn't know if what you saw was living or dying. I mean, the seasons there changed so fast that the whole question became irrelevant. And I think at some point with stage 4 cancers, it's an irrelevant question. The person is alive until their last exhale. That's how we define it. But the quality of what they're doing in that time, one of those choices is, not even a choice, one of the realities, they're likely to die. So what do you think? Do you think that kind of a shift could be put on the table, or do you think the culture isn't ready for it? Do you think it's too out there? What do you think?
Well, that's hospice. I mean, you just
That's not hospice.
No, you did.
It's
You
part
just-
of hospice.
You described hospice to a T.
No, I don't think I did. So that's good. We have a disagreement.
Okay, we're getting started up.
And-
What's missing? What part is missing?
What's missing is that, at least from my knowledge, hospice usually comes in towards the very end,
Okay, so we're talking about starting the conversation way in advance.
way before
That's
in as a
panel.
Okay.
no, it's a course.
Oh, no, I'm joking. I mean, that's what I do, and that's what we've been trying to do with our end of life discussions and bringing this on in, because and again, it's less so in cancer as it is in chronic disease processes, because we're now the baby boomers who are in their 50s and 60s are taking care of their parents who are in their 80s and 90s, and no one's had this conversation with them. And so we were attempting to do that and attempting to bring that in, because I'm not paid to sit down and talk to you. I could talk to you to a blue streak, and I'm not paid to do that. That is not what I get paid for. I get paid a lot of money if I give you a shot. I get $168 for that 10-minute procedure. But to sit down and talk to somebody about what's important, preventative types of things, death, what death will look like, that's not rewarded. And in the attempt, our attempt to sort of bring that into the conversation, to recognize that as an important component of healthcare, unfortunately was shot down. And
Okay, fine. Let's
that's
forget
fine.
let's stop looking to you guys to make all the changes here. I mean, maybe we have to do this ourselves. And I studied the baby boomer population for several years when I worked at the oldies radio station in town, and they're so huge. And I love that demographic because they have parents who are dying right now. They're also starting to deal with their own mortality. They have children and often grandchildren. They also, were hippies, and they've been exposed to all these different kinds of things. I think they're going to be the ones that change the course, because they are going to want to talk about it. They're going to want to explore the options. And, now that medicine can, keep us alive longer, they want quality to be part of that. And so I really look to the baby boomers and the younger generations to say, like, hey, we need to just start talking about this. And we have to, perhaps it's a grassroots effort.
Well, but you slip into it. I did a talk just 2 weeks ago, last month, so it's more than 2 weeks ago, to a group of physicians. Anybody around here, if I said, you're going to wake up tomorrow and you're going to be laying in bed and you're not going to be able to talk, you can't feed yourself, you can't bathe yourself, you can't stand up, and you're not going to be able to recognize anybody around you, you'd say, that's not quality of life, I wouldn't want that. But how do people get there? And they get there because it happens slowly, piece by piece, and we continue to treat. And so by the time we get to the point where we should be thinking about it, we're no longer cognitively capable of having that discussion or cognitively able to do it. And so we are obligated by law to continue to do everything we possibly can unless somebody says otherwise.
Which is why I think that when a patient is given a diagnosis of, you have stage 4 pancreatic cancer, and here are your options. You can have this kind of chemo, you can have this kind of treatment, and as well, here's a course that you can take looking at what you can learn from this disease and looking at what this disease is probably going to present to you, and starting to look at death and starting to have that conversation. And so it's not in the last 3 weeks. It's given along with the prognosis.
Yeah, why wouldn't that be just part of the medical system? It would make your job so much easier.
Well,
Is it a financial thing?
No, actually there are some groups in town that are beginning to take that approach. They sit down, there's a group
But that's a group. Are doctors saying
no,
that?
an oncology group is what
Okay.
I mean. Okay, excuse me, medical speak. An oncology group on the west side of town actually has taken on that approach, and that's what they do. They'll sit down in the very beginning and have that conversation, and that I think is sort of key to what you're saying, and to what you're saying too, is it's very fair to sit down and say, this is what we've got. Okay, this is the disease that we have, and it's in a box, and we're going to move forward, and we want to have you cured, or we want to put you into remission, or we want to be able to treat this as a chronic disease for as long as we can. But the next part of the question that doesn't come up and should come up is, and if it doesn't go the way you want it, how much are you willing to tolerate?
I'd like to close out this discussion just real quick. Shani, a lot of what you teach is dealing with nutrition. And I heard a statistic that, 80% of your immunity is found in your digestive health. And so really figuring out how we are going to start working with nutrition as a form of prevention. Perhaps we start the conversation there and then slowly peel the onion on this. Could you speak quickly
Again,
about
that would
the
be
importance?
ideal, is to start it much earlier and have people understand the importance of it. But usually it comes up, for many people, it comes up right in the middle of that stage 4 diagnosis, or when they're in treatment, after that even, and their bodies start to fall apart. So there's a lot that can be done to support people such that they are able to even withstand their treatment. There's quite a lot that can be done through avenues such as nutrition and others that would make them so much healthier, or at least in charge of themselves during the process. So it's a lot to withstand, but there's a lot we can do to offset it. And I think the medical community in general is not taking advantage of what's out there, the experts who are able to work with them to have that happen.
We have to wrap this up, but I want to just say one more thing, is that I heard there is a test, though, that if you do have chemo treatments coming up, there's a test that helps distinguish how well the body can accept it. Yes. Is that being offered regularly? Is that, Glenn, maybe you're the...
My experience is that I'm the one that offers that. The MDs will never offer that. I've yet to see that come out of the medical community. These chemo compatibility tests where... of the chemo choices available, which one actually matches the cancer we have in front of us.
Yeah.
It is available. It's typically privately funded, rarely by insurance, and I'm usually the one to tell the patient about it.
Great. I'm so glad we mentioned that. And, I want to say that, I really love what we've brought to the table here, too, of just talking about, changing the language around this and having other options. Let's just do what we can to bring these kind of conversations to the forefront so that death, again, is part of life, part of acceptance. So thank you very much, all three of you. Hopefully this is the start of something big.